Good morning, students. Today we are going to discuss about drugs used in rheumatoid arthritis. So, what are rheumatoid arthritis? There is an introduction to rheumatoid arthritis. It is an autoimmune disorder which is characterized by increasing the levels of cytokinins like TNF alpha, interleukins, and some neutrophilic migrations. It causes destruction of joints, which produces prostaglandins, which is responsible for pain or inflammation. Let us discuss about the features, how this rheumatoid arthritis looks like. If you see in the picture in the right side, there are inflammation in the joints. Synovial proliferation is also associated, finally, which causes destruction of cartilages. What are the treatment options? The treatment behind this rheumatoid arthritis basically divided into two classes. One is symptomatic relief. The second category is improve the conditions of the patients by reducing the disease progression. So in the first case, symptomatic relief, the drugs used are non-steroidal anti-inflammatory drugs, whereas the second agents which can control disease progression are disease-modifying anti-rheumatoid drugs or slow-acting anti-rheumatoid drugs. So let us basically divide it into two major classes, that is NSAIDs, DMRDs, that is disease-modifying anti-rheumatoid drugs. In the other class, these anti-rheumatoid drugs can also need some adjuvant therapies, other anti-inflammatory agents like glucocorticoids, prednisolons, and these disease-modifying anti-rheumatoid drugs are further be classified into two major classes. One is synthetic, the other one is biologicals. Let us start with disease-modifying anti-rheumatoid drugs. These are the agents that modify the progression of disease, and they are also called as slow-acting anti-rheumatoid drugs. These are to be started as soon as the diagnosis is confirmed, and this can either be used single agents or could be given in combinations. But on longer duration, its effectiveness will be reduced. And already they are classified into two classes, synthetic and biological has been mentioned. So let us start with synthetic disease modifying anti-rheumatoid drugs, which are started with non-biological. They are further divided into categories like immunosuppressants and immunomodulators. In the immunosuppression category, the drugs what we will use, they are cytotoxic agents like methotrexate, azathioprine, and cyclosporine. Whereas in immunomodulators, drugs are sulfasalazine, hydroxychloroquine, leflunomide, and tocilizumab, or you can say these antibodies are also used. Whereas in the biological disease-modifying anti-rheumatoid drugs, we are said these are recombinant proteins obtained from monoclonal antibodies. Either they may be obtained from living organisms, and that is the reason why they are called biologicals. These biological agents are classified into two major classes like TNF alpha inhibitors, which are the major component, drugs like etanercept, infliximab, adalimumab, whereas the other agents like anakinra, abatacept, and rituximab. Let us start with synthetic disease-modifying anti-rheumatoid drugs that are methotrexate. Methotrexate is commonly known as the mechanism they inhibit dihydrofolate reductase. So in the picture on the right side it mentioned dihydrofolate should be converted to tetrahydrofolate in presence of enzyme dihydrofolate reductase, and this tetrahydrofolate is required for productions of DNA and the other related things like purine synthesis, amino acid synthesis, And further, these syntheses are required for productions of cytokinins, for maintaining the chemotaxis, for maintaining the immune functions, as well as for proliferation of immune cells. So all these things will be hampered if dihydrofolate reductase will not be there, because dihydrofolate is not converted to tetrahydrofolic acid, and finally your purine and amino acid synthesis or conversions will be stopped. Coming to the kinetics of methotrexate, they are rapidly absorbed and they are showing 50% plasma protein binding. Most of the drugs are excreted from body unchanged. So this is the reason why they are not recommended in renal failure patients or patients having impaired renal function. Their uses are rheumatoid arthritis, especially they are preferred as oral low dose, that is 7.5 to 15 mg per week. Other than this could be useful for psoriasis, acute lymphoblastic leukemia, for cancers like bladder and breast cancers. The second class of drug in same synthetic disease modifying anti-rheumatoid drugs are azathioprine. It suppresses the purine synthesis, it gets converted into monoribonucleides, and these monoribonucleides are further inhibit the conversion of inosine monophosphate to the bases like adenine and guanine. So finally the purine synthesis will be inhibited and it incorporated into RNA and DNA, and further it renders their functions loss, which cause dysfunctional of these DNA or RNAs. Finally, they suppress cell-mediated immunity. So selectively, they can affect differentiation and function of T cells as well as natural killer cells. Approximately, these are used in rheumatoid arthritis in a very low dose because of its potency from 1 to 2 mg per kg per day. Remember, azathioprine is never be combined with drugs like methotrexate. Then we can discuss about our next compound, that is your combination products, that is 5-amino salicylic acid is combined with sulfapyridine in a linkage that is called azo bond, which is given in the picture, and these products is useful for control of rheumatoid arthritis. So what is that products and what are the usefulness? The interesting thing about these two products, 5-amino salicylic acid only be useful as inflammatory bowel disorder. They are drugs which can control inflammation and they can be absorbed and exhibit systemic effects. But remember, these 5-amino salicylic acid could not be absorbed, but sulfapyridine is a drug which can absorb and they can produce a systemic effects. So in combination of both, the presence of sulfapyridine will enhance the absorption as well as produces the anti-inflammatory activity. So generally these amino salicylic acids we are discussing about A and A, their absorption is nil, whereas S and E, which is highlighted in red color, is showing these are responsible for systemic effect. So that's why this combination is useful for treatment of rheumatoid arthritis, and this is useful as a second line agents for milder cases. It can also be combined with methotrexate. Let us discuss about the adverse effects. Neutropenia, that is the sodium level will be reduced. Thrombocytopenia and hepatitis could be the common adverse effect associated with these agents. Then hydroxychloroquine, this can reduce the monocytes, interleukin 1, B lymphocytes, and antigen processing, interfered lysosomal stabilization, as well as free radical scavenging capacity. So ultimately, they could be useful for treatment of rheumatoid arthritis. Why? Because they can reduce the interleukins and B lymphocytes, which are top inflammatory mediators. And dose is 400 mg per day. Then it's for long duration treatment and used in milder erosion or erosive cases of joints. It can be given in combination with methotrexate and sulfasalazine and useful in malaria. Then comes the immunomodulators. Leflunomide is a potent immunomodulator, rapidly converted into active metabolite. This inhibits dihydroorotate dehydrogenase. Pyrimidine synthesis is also be inhibited. So finally, cell proliferation will be decreased, will be reduced, and antigen productions will also be reduced by suppressing these beta cells or B cells. Then the last category of drugs are TNF alpha inhibitors, etanercept, infliximab, and all these which discussed earlier. These are soluble TNF receptor proteins or antibodies which can target TNF alpha and inhibit them. So if TNF alpha is not available to bind with TNF receptors, they can target these macrophages and these functions of T cells, and macrophages will be suppressed. So that's why they are useful as a quicker response disease modifying anti-rheumatoid drugs. They can be given in combination with methotrexate. Adverse effects are acute, worsening cardiac heart failure and immunogenicity. Then the last drugs which are already used, we know that corticosteroids and NSAIDs, the adjuvant therapies, potent immunosuppressants and anti-inflammatory agents can be used when potent anti-inflammatory actions is required. NSAID provides symptomatic rheumatoid relief, and disease-modifying anti-rheumatoid drugs required to retard the disease. Methotrexate is preferred in treatment of rheumatoid arthritis, but not to be combined with azathioprine. Sulfapyridine or sulfasalazine is the active components. Hydroxychloroquine already we have discussed for rheumatoid arthritis. So this is a quiz. All of these following drugs are useful in rheumatoid arthritis, except, so I'm giving a pause. You can answer what may be the question for this. Allopurinol, methotrexate, rituximab, or adalimumab. I hope you could answer. Answer is the allopurinol. So in next class we'll discuss about the drugs in gout. Thank you for your patience listening. If you have any doubt, we'll discuss the same.